Hi, this is Dr. Paul Thomlinson from Compass Health Network, and I'm doing a continuing series applying evidence-based psychology to the issues and concerns of these times we're living in and living through. I hope what I have to say today will somehow contribute to our mission of inspiring hope and promoting wellness. This is a special two-part episode for May as Mental Health Month. I want to talk to you first about what we know about the mental health impact of this pandemic we've all been in for just over a year now. In part one, I'll talk about what I believe are 4 myths about mental health and the COVID pandemic. Is this likely to be a mental health disaster or an epidemic of resilience, or maybe both? And in part two, I'll give you an overview of what the latest research says about vulnerability and mental health in the pandemic, as well as an introduction to a program I'm very passionate about and which I highly recommend called Mental Health First Aid. And it's a powerful and effective way to be equipped to recognize and help with mental health issues, including your own. So here we go, part one, myths of mental illness and resilience during and following the pandemic. Since we're all hearing nonstop about the COVID vaccine, I want to start with the subject of vaccination. What is the purpose and effect of a vaccine if not to encourage and create in us a resilience against the virus? That is, the ability to fight it off. And no one needs the vaccine more than those who are most vulnerable. I want to assert that we should be thinking in those same terms about mental and behavioral health matters. No, we don't have a shot in the arm to prevent mental health challenges or substance use problems, but we do have many ways of creating more immunity to them, more resistance to them. That is, we have ways of creating resilience against behavioral health disorders. I don't think we should really talk about mental illness or substance use disorders without also talking about resilience or inoculation to them. One of the great psychologists of our day, or any day in my opinion, is Dr. Marty Seligman, often referred to as the originator or father of positive psychology, which is the study of human flourishing and wellness in contrast to human deficits and pathology. I think it's fascinating to note that in his early books on learning optimism, he mentions that his childhood hero as a scientist was Dr. Jonas Salk, and you will all likely remember him as the one responsible for the virtual elimination of polio through the development of his famous and history-changing vaccine. Well, I also think it's important to remember how vaccines work as a wonderful analogy to how human resilience works in a psychological sense. Whether old or new, the basic mechanism is that the vaccine introduces a challenge to the immune system. And then the immune system does its near miraculous job of creating antibodies or new immunities that allow us to fight off new challenges, to reduce infection, reduce serious illnesses, and reduce deaths. I'll be absolutely delighted when our psychological and behavioral inoculations are as effective against mental illness and substance use as these new vaccines are against COVID-19. They're virtually 100% effective in preventing serious illness and death. And that should be our goal for mental illness, substance use disorders, and suicide as well. So we've seen some of the mental, emotional, physical, financial, spiritual, and social impacts of the pandemic on the folks around us, and how they vary greatly. But it drives home the point that none of us have been unaffected. And before I talk more about what we know about regarding the mental health impact of the pandemic, I want to talk more about resilience, true to my word. In particular, I want to dispel some misunderstandings or myths about resilience during this pandemic. So I've been paying very close attention to the published scientific literature as well as the media reported headlines on the mental health effects of the pandemic for nearly a year now, and my files have hundreds of articles in them. I can't tell you how often I've heard something like the headline from USA Today last year. Quote, mental illness is epidemic within the coronavirus pandemic, unquote. You can find literally hundreds of such dire predictions about anxiety, depression, substance use, suicide, and other terrible scourges. Now, I'm in no way saying we shouldn't be concerned about these things, obviously. Treating them is what all my colleagues and friends at Compass Health Network and I have devoted our existence to. But it's not the whole story, and I want to focus on the other crucial side of the equation that we're also devoted to. What I mean is, as trauma researchers from the University of Washington, Pekanga et al., have put it, quote, these dire predictions likely underestimate the impressive human capacity for resilience. Why not forecast an epidemic of resilience? Unquote. It would be scientifically appropriate to do so because resilience is by far the most common response to experiencing trauma. It is the normative and modal response, the most common response. Now's the time to build individual and community resilience, not only to protect the vulnerable among us, who have factors predisposing them to mental illness, but also to move us towards psychological or mental health herd immunity. Another analogy I think is really apt. So I want to talk about some of the myths that they point out, the Pekanga et al. Point out, that might need to be dispelled in striving for that goal of psychological herd immunity. Myth number 1. Mental illnesses like PTSD and depression are inevitable following exposure to traumatic events. Well, it just isn't so. For example, large studies of first responders years after the 9/11 attacks showed that about 14% had clinically significant signs of PTSD. And among healthcare providers following the last large SARS outbreak, only about 10% showed such signs. Yeah, we're in a whole new ballpark with regard to the size and scope of this pandemic, but there's no reason to believe that we will not see solid and long-term resilience as the most common outcome. Myth number 2. People who are resilient don't have mental health rough patches. Of course, this is nonsense and a limiting myth. In fact, as I mentioned, just as the challenge to the immune system in the vaccines creates new immunity, it's the very mental health challenges we are all facing that creates in us resilience. I like how Pekanga et al. Put it. Engaging in adaptive behaviors while struggling and while experiencing intense fear, anxiety, or grief is resilience. Adaptive behaviors. Learning how to adapt to new and difficult circumstances. And resilience looks very different for different people because we are all different and have all experienced our challenges differently. We may all be in the same storm together, but we are definitely not all in the same boat. What do I mean by that? Well, losing a job when you have a year's worth of living expenses in the bank account is an entirely different experience than losing a job with $27 in your account. Resilience will likely look very different depending on whether one is facing the prospect of homelessness, possibly witnessing multiple deaths, or having someone you love become very sick. It may look like the following. 1. Just continuing to breathe in and out and put one foot in front of the other every day. 2. Working up the energy to engage in active problem solving, looking for a new job, looking for a new place to live, or looking for social support. Or 3. Sharing with others that you're struggling right now. That's a sign of resilience. Learning to make friends with or at least tolerate excruciating uncertainty. I did a podcast on that early in the pandemic. Or how about this one? Finding new ways to have and experience hope for our futures. That's the essence of resilience. It's not about not having rough patches. It's about continuing to show up, to move forward, to use what resources we have, even when we are at our lowest points. Myth number 3, you've either got it or you don't. Well, the evidence argues strongly against this idea. In fact, as much as we like to think that grit and resilience are set in concrete, or just kind of the way we are as people, we know that it's something that is actually shaped, honed, and fashioned by the environment, by our thinking patterns, and by our behaviors. And therefore, it's something that can be improved greatly if we don't have enough of it yet. It might surprise you to learn that things like family history or even existing mental health problems or psychiatric illnesses do not predict very well who shows resilience to traumatic experiences or adverse situations and who does not. So what is the better predictor? I thought you'd never ask. It turns out resilience is best predicted by the development of social support, which that's a drum you've heard me beating for a long time now, and the use of adaptive meaning making. A fancy way of just saying finding the meaning in the suffering, if you will. Finding ways of finding purpose and meaning in the midst of all this. So all that argues for the fact that resilience is acquired, learned, shaped, developed, improved. It's not a fixed characteristic that we either have or don't. We also know that we as individuals and our communities can help each other to cultivate resilience. The reciprocal influence of community and individual human beings is undeniable. So what examples have we seen during the pandemic? I personally know of quilters and sewers, crafters, who have sewn and donated dozens or hundreds of cloth masks. I've seen the owner and manager of one of my beloved Starbucks here in Springfield has put up signs in the drive-thru with the messages, "We'll get through this together. You matter. Kindness is its own reward," etc., among many others. How many collective thank yous to healthcare workers have you seen? Heroes work here banners, and dozens or even hundreds of people standing 6 feet apart and joining their voices to sing "Stand By Me" to nurses and doctors leaving the hospital after their shift change. Homegrown support networks like weekly COVID check-in Zoom calls, Zoom happy hours, etc. have been all over the place. There have been all kinds of ways that we have learned as a community and as individuals in community to develop resilience. Psychological herd immunity is the goal. And I'm sure you have your own favorite examples of those. So the bottom line is this. These kinds of things contribute to the social capital account. They put it into our bank account of social capital, and they can and do make a difference. They buffer against the development of psychopathology, mental illness, depression, anxiety, even psychosis, by giving us a sense of purpose, meaning, and self-confidence, that we can weather the storm with a little help from our friends. The last myth, number 4, mental health risks of the pandemic are a hoax. That is a myth too, obviously. This may seem like I'm talking out of both sides of my mouth because I've been talking about the epidemic of resilience, but there's no question that there are serious risks to our mental health afoot these days, especially in the short run. Of course, we expect to see mental health symptoms, short-term distress, and an increase in mental health crises among those most strongly and directly affected by the pandemic. We must not ignore those things, and of course, we are not. We should also be thinking about the more widespread secondary mental health effects, if you will, or what we might think of as the downstream effects. For example, one of my early podcasts was where I worried about those who have been isolated in unsafe environments, such as in homes with a violent domestic partner situation. I've worried with good reason about the isolating effects of stay-at-home orders, social distancing, etc., on people who have already established unhealthy patterns of social isolation, etc., possibly causing a deeper dive into depression for many. So there clearly are secondary effects we need to be worried about. These are all the kinds of things that call for us to be watchful, to do what public health officials call surveillance, watching for when normal reactions to stressful events turn into more dangerous mental health crises or disorders that impair our ability to function and that need treatment. We should be looking for ways of normalizing the first one. Of course, it's normal to be anxious in the face of unprecedented danger, illness, death, and uncertainty. That just tells us your nervous system is working properly. The latter, though, when it doesn't relent, when it gets worse, when it lasts for weeks or months and impairs our ability to love and live and work and play, then it's something we should really get some help with. Maybe from some professional with the same kind of alphabet soup after their name as I have, like the MA, MS, LPC, PhD, PsyD, LP, MD, APN, LCSW, etc. But what I really want to leave you with today is that these kinds of problems are not only, or simply cannot be only, the province or responsibility of mental health professionals only. Our communities have both the opportunity and the obligation to identify those who are most vulnerable and hurting and to put in place those things we know can improve our resilience, such as creative ways of providing ongoing positive social support and helping make meaning during these times that we're in. Collective meaning. That equals herd immunity, just like individual meaning gives us individual immunity. Come back for part 2, where I'm going to talk more about what we know about vulnerability, and I want to introduce you to mental health first aid.